Hi, welcome to Glenohumeral Gurus, a podcast for clinicians with an interest in shoulder pathology. I'm your host, Margie Olds, and it's a pleasure for me to bring you these podcasts. The aim for the podcast is to deliver some clinically relevant content for you, and we aim to take around 15 to 20 minutes. I plan to interview people from all over the globe and talk to clinicians and researchers and anybody with an interest in shoulder pathology so that we can learn how to help these people better. So settle in and enjoy the podcast. Hi everybody, welcome to Glenohumeral Gurus. In this podcast, we talk with Professor Gisela Sole, who's a professor at the University of Otago in Dunedin, New Zealand. She's recently published a paper entitled The Glass Shoulder. That's a qualitative study that investigates the impact of shoulder dislocation on people's quality of life and the other impacts of a shoulder dislocation. I'm sure you will enjoy this discussion. I found this work to be incredibly powerful, and it influences how I deal with shoulder instability patients in clinical practice. So I hope you enjoy. Hey, it's my great pleasure to welcome Professor Gisela Sole to the Glenohumeral Gurus podcast. Gisela, welcome. Thanks for your time.
You're welcome. Thank you for inviting me, Margie.
Yeah, it's great. I wanted to really share with people about this glass shoulder project. But before we get there, and I get too excited, and so can you share with me your journey to how you get here? Maybe a little bit of your physio background, just to introduce yourself to the audience.
Yes, sure. I'm a physiotherapy trained academic now. I trained at University of Stellenbosch in South Africa, and then worked a few years in hospitals in South Africa and 4 years in Switzerland in a hospital as well, and then into a private practice. And then I came to a stage where I thought I need to do something more than being with patients all day. It was about 8 years of clinical practice first. So I returned to South Africa, this time to University of Cape Town, and did an honours in exercise science under Professor Tim Noakes. And that taught me to be critical and analyse what we are doing, and not always doing things like we were taught. So getting me out of that mode was an excellent year. I then joined the Cape Town University Department of Physiotherapy, so started teaching, because I didn't know what else to do, and that was an opportunity that came up, and I thought, well, I might as well just try teaching. So I taught undergrads and postgrads in musculoskeletal and sports physiotherapy, and that was in physiotherapy and also in the exercise science department. And then I happened to be on a scientific committee of the conference of the South African Sports Medicine Association in Cape Town. This goes back to about 93, somewhere around there. And the invited speaker for shoulder pain had to withdraw 2 weeks before the conference. And then the committee said, Gisela, you'll have to be the expert. And I said, what? So in 2 weeks, I had to put a talk together. And there happened to be an orthopedic surgeon. His name was Joe De Beer in the audience. And he afterwards asked whether I could work with him for his patients. So it's all these little coincidences that come at times where you don't think anything will happen, but opportunities come up. So while I was working at Cape Town University, I also saw some of his patients late in the afternoons, and he taught me so much about surgical management of shoulder pain. At that stage, he was already doing latages for patients, and particularly rugby players with shoulder dislocations. But then I came to Otago, so the family moved to New Zealand in 2001. And I first had to do a PhD, which I was very fortunate, it was part of my job. But I couldn't find a supervisor in shoulder pain. So I veered off, did something on hamstring injuries. But after I completed the PhD, I thought I'll return to the shoulder. And I've done a few laboratory-based studies, and now I'm doing some clinical studies. And then I started with qualitative research. And another interest of mine was the anterior cruciate ligament field, where with students we interviewed patients with those injuries and started to realize what might be underlying fear of re-injury or fear of pain.
Yeah.
So that is my background.
Yeah, right, which is fascinating. I've learned lots and lots. I didn't know about you. I've been working with you for a couple of years now, and I didn't know all those things. I think, just broadly speaking, it's about making the most of the opportunities that present,
Yes.
isn't it?
Yes.
Because some of these things have just sort of randomly happened through your career, and there's an opportunity, and you said yes. So there's some really nice learnings for people just listening to your story. I think if you think then about this glass shoulder work, can you share the background? Do you think like it draws, doesn't it, from the ACL research around fear of re-injury and your qualitative skills around interviewing people? Can you share the background for that paper?
Yeah, I think the idea of the paper came in a conversation with you, Margie, where we were considering what needs to be done in the field of shoulder pain and research. And I mentioned the ACL-related studies that we've been doing, and the commonality between people with ACL ruptures, whether they get surgery or not, and shoulder dislocations, whether they get surgery or not. The commonality is that high fear of re-injury. And the reason is real. They do have a high risk of re-injury. I think there's one statistic that even after a Latarjet surgery, for men, about 50% of them can still re-dislocate after the surgery. That's one statistic. It ranges between 20 and 80%. I think that's what the literature tells us. So as for ACL ruptures, there's a high risk of re-injury. And that is one of the reasons why people often don't return to the sport to the same level over longer time after such injury.
Isn't it?
Even if they do get surgery. I think in the ACL literature, I think there's a statistic that only 55% of those with reconstruction return to the sport at the previous level for more than 2 years. And then they drop out for various reasons. Sometimes it's life reasons why they drop out. And the same, very similar, is for shoulder dislocations as well. So we need to understand more about the patient's or the sports person's perspective, how they experience their injury, the surgery, and the rehabilitation, and then recurrence, re-dislocation, so that we understand what they go through, and in order for us to better serve them.
Yeah, because I think when we look back at the literature, there's such a lot on rate of recurrence and how many of you had, and I think now we're just starting to understand the impact of fear, and I guess that was one of my drivers when we started talking about this, was all about the fear, and then I was really humbled to learn it's way bigger than that, isn't it? That's what I learned from our study. Do you want to share with people the process, I guess, and then what you think are the key findings from this study?
Yes, I'll do that. Before I go to that question, since we've done our analysis, I've learned via the Department of Psychology here that there is a distinction between fear, hesitation, anxiety. So in our paper, we don't make the distinction very clearly, but there is a distinction. And I think new studies that will come out will go into that deeper.
Do you want to just share with us the broadly speaking then, the difference?
The fear is often what is happening on the moment. You feel fearful, where anxiety is the more long-term. And I'm not going to go back on the sports field because I'm anxious that there might be an injury, a re-injury. So, and there are also physiological responses to that, which I can't really explain. But it's like always, the deeper you go into a small field, the more differentiation you find.
I think that's what I found, because I too have looked, because I've been trying to understand fear a lot more really since we found that kinesiophobia was a risk factor for recurrence in my PhD, then I really wanted to understand that more. And we know some of the physiological responses, such as, pupils and skin sweating and elevated heart rate. There's all those, because I've been thinking, maybe I could try and measure those things in these people. My understanding from some of the research was fear is something that you, and just very anecdotally, fear is something that you run away from, whereas anxiety is an emotion that you feel but choose to re-engage with. So I guess there's different definitions as well, isn't it? And so is it really fear of re-injury, or actually re-injury anxiety, as some people have defined? As we.
So in our study, well, I'll come to the key findings, main themes, and fear is part of that. So we'll carry on with that point as well. So the three main themes, we had 14 participants, and they were recruited via our social network and also from specific clinics. And there were, of the 14, there were 2 women and 12 men, and that is quite common. It's traumatic sports-related shoulder injuries are more common in men than women. And they came from all different types of sports, even from surfing. So, and also rock climbing was another mechanism of injury. So it's a very heterogeneous group of participants. And we also need to remember that what we found, that the themes do not necessarily apply to every person with a shoulder dislocation, because we attract people to these studies that actually still have lingering problems and who really want to share their experiences. Those that do well often think, oh, why should it be part of that research? But we did have some of them were really were reporting that they did well and did not have all 3 of these themes. But the themes were, the first one was downward wellness spiral. That includes that shattering response to the injury, or the injury is a life-shattering experience for many of them. And there was an immense feeling of loss. And that loss actually went into the second and the third theme as well. It's not only loss of what they're capable to do with the shoulder, but also loss of their place in their team, which most physios know about. But then also loss in social activities. So they couldn't be invited anymore to go tramping. One participant can't, because she was afraid of carrying a backpack. So that she was being excluded by her friends when they were going out. And one person said that the only time he's now seeing his friends is when they're drinking. Because if they are going out for the party, there may be a chance that he would re-dislocate the shoulder. So under that downward wellness cycle, it is the physical aspect of the shoulder, but also the emotional and the social isolation that they experience. Some of them reported going through immense depressive phases. With one person says that his quote was, when I said to my girlfriend, if this happens again, I will top myself. So suicidal thoughts. So it's not all, and then again, I want to emphasize that this is definitely not everybody with a shoulder dislocation, but some people have those really, really strong and significant downward cycle.
And I think, like you say, we need to acknowledge that is probably a bias of the people who selected to come into the study to have these discussions for you. But I was slightly embarrassed to think that I wanted to know about fear and they were having suicidal ideation thoughts, and so not everybody, obviously, but the impact, the social isolation that we need to be aware of. It's not really about fear and can you get playing to sport and how many times have you had a dislocation. I think was some of the key work there. The other themes, share with us.
So the second one was out of arm's reach. And that explains or describes the experience of that. These people had undergone rehabilitation. They spent hours with a physiotherapist over many weeks. And they did everything that the physiotherapist asked them to do, even had surgery. But despite of that, there was a redislocation. And they just knew the extent of the commitment that they had to start all over again. So it was as though they were hoping for a stable shoulder, but that stability was sort of out of arm's reach. They thought they regained it, but then something happened and they redislocated the shoulder. So that's a repetitive rebuilding of confidence and hope. That was one of the sub-themes. A very important sub-theme there was that fear and apprehension. And they described it very differently. Some said, no, it's not so much fear, it's just avoid. So it went into avoidance, which is basically the third theme. So they're just avoiding the activities that they know they would be at risk. One person I remember said that it's a gut-wrenching feeling. Just thinking about himself going back into a scrum, he gets that gut-wrenching feeling. And that's probably, I don't know whether it's anxiety or fear. So it's avoidance, that feeling, gut-wrenching, but then others just say, well, it's just that hesitation before I throw the ball, and that instantaneous needing to make a decision, am I going to throw the ball or not? And so there's where the avoidance comes in. So instantaneous decision-making, which is basically the third one more. So they describe the fear and apprehension. The reason why the fear is not just the injury. For some, it's the pain. They described that incredible pain happening while they're dislocated. Very similar to people with ACL reconstructions, where you can see the pain on the face when it happens. For example, nipple players. For the shoulders, what came out, some said, well, just seeing that shoulder dislocated, just that in the peripheral vision, it's just such a negative experience that they never want to see that again. So it's just the brain just can't cope with that. And then that is being edged into the brain, in a sense. They can't get it out of the mind. So it's the experience of the actual injury that feeds the pain or the fear or anxiety. For some, it was also the experience of getting to a hospital. They may have taken 3 hours to get to a hospital and then have to sit there for another 3 hours before eventually it's being relocated, and then again with pain. So that experience, that immediate experience, feeds, and they never want to go through that again. And then afterwards is the long rehabilitation. And that there the therapeutic alliance comes in, which I'll come just now. And then also life changes for some people. They may have children that they think, well, I will not be able to rehab to that same extent again. So I must just avoid, I must just not be in the position of re-injuring my shoulder. So it's not only about the shoulder, it's about the experience and then also life commitments that they definitely do not want to go through that again. And all of that adds towards anxiety and fear or hesitation. So the last sub-theme under out of arm's reach was the therapeutic alliance. And that highlights the importance of as clinicians, our relationship with the patients, how important they find that information to build their hope and confidence. It's the words that we use. We know that from other studies as well, how we word things for the patient, how we build them up, and how we are aware of their emotions and their responses. They mentioned positive and negative aspects, and even one person saying that he's avoiding a particular clinician now because he feels or she feels that the clinician is not listening to them, is not listening to their perspective. So the therapeutic alliance is incredibly important from that perspective, from the patient's perspectives, in building confidence.
Isn't it? And I guess always putting the patient at the center of that, where they're empowered to make their decisions as they want to make their decisions, really entering into that shared decision-making process wholeheartedly, not sort of without judgment of what the patient then might choose as well, I think.
Exactly. Yes, that's right. And then the third theme was the obligatory compromise. So there came a time where they described that they just had to accept that they might not have a stable shoulder for the rest of the year. Again, it's not for all, it's for some of them. And they had to come up with some risk mitigation and compensating. Some of them said, one person, for example, said when he washes his car, he has to be careful not to fatigue the shoulder too much, because he perceives when the shoulder is fatigued, then it's more likely to be at risk. So they were each individually figuring out what they had to avoid. but also what they could continue doing. So from a strength-based approach. So there's that compromise and acceptance that is really important. And the third sub-theme there is rehab for life. So it is about realizing that they can't just rehabilitate and then be discharged and then they'll be fine. They know, they've realized that they have to carry on maintenance exercises to keep the shoulder strong. And in a sense, one can visualize that the brain will always try to protect the shoulder, and that avoidance will always be there. Directed from our central nervous system. So it's you constantly have to do exercise, partly to maintain and build confidence, because confidence goes up and down, and then also to keep the shoulder strong, and keep the whole body healthy.
Can you remind people, the population of people that you interviewed, they were both surgical and non-surgical, and primary or recurrence, or all of them had recurrence?
No.
There were some there that were the first time.
So some had Bankart, some had Latarjets, arthroscopic labor repair. I've got it here in front of me.
Okay.
Actually did not have rehabilitation. There were about five of the 14, I think.
So they
that
weren't
were rehab only.
They weren't all surgical candidates, were they?
They
were a mix, and they were also, there were any that they had all had multiple episodes of instability.
Yes, and some of those had dislocated after surgery.
Right.
But there were also one or two who had not redislocated and were very confident about the shoulder. And those were more likely, like, we have to be careful not to generalize based on 14, but there was at least one person I remember who had a desk job. So in a profession, highly qualified profession, but it was a desk job, and he thought that his occupation was not influenced by his shoulder. But he had a gym set up in his house, and he was doing regular training. And others said that they were going to gym regularly to maintain the shoulder strength. There was at least one person who was very concerned about their tradesman occupation and whether he will be able to continue. And it was a job that he really loved, and that was another part that fed into his anxiety and his fear, whether he would lose his position or not. So it really also, how much the fear and anxiety is probably also dependent on requirements of life, requirements of their occupation, their sports, their hobbies, and the type of social activities that they like doing. For example, a person said they're fearful now of surfing, because what if they redislocate when they are 100 meters away from the beach on a wave? So thinking of the possible consequence if it should happen again, or rock climbing, they wouldn't be able to do, because what if they're in the mountains 4 hours away?
I mean, I've worked a lot with kayakers as well, and you hear some horrendous stories of them being upside down in the water, unable to breathe with a dislocated shoulder. You know, the impact of some of these, they really become then life and death, don't they? Rather than, than some of these other factors. I have two questions, one of which I haven't talked to you about. I've been talking with some researchers about fear and anxiety, and whether some of it is remembered fear, and we've seen some MRI studies that show that it might be evoking a memory, or there might be some physical translation that triggers the fear, or I wonder whether there's an emotional component. Do you have any ideas around categories of this? What are your thoughts there?
I don't know of categories, but we do know that any injury and any pain does influence how we process how our brain processes. So we call that neuroplasticity. So there are changes, as you say. I'm not sure what has been done for people with shoulder dislocations, but in the ACL field, there are now more studies that use functional MRI and while the person lies in that tunnel, they're being asked to do knee extension flexion, and that can monitor how the brain responds to that movement, or how it is activated while doing a movement. It's more difficult to do those kind of studies for the shoulder, because you can't lie there and move the shoulder. You'll be hitting the MRI, the equipment. So we know from ACL that there are changes that one can monitor when compared to controls. That's all. Those are the type of studies that are being done at the moment. And I would say that similar would count for shoulder dislocation as well. And that's the neuroplasticity following injury, and that probably then highlights how that experience changes our emotions, any response, physical responses, emotional responses. But the good news is neuroplasticity, it's plastic, so it can change over time.
Modifiable,
We just don't know how it changes over time.
Which is interesting, because there have been a couple of studies looking at functional MRI in people with instability, and that is what they see, you know, in those emotional centers, and also in memory where that lights up. But yeah, like you say, these are just snapshot studies. They're just one-off. We don't know if it changes over time, and as a clinician, how to change that over time as well. Like, other than, you know, we know what's important from this study with the language that we use, don't we, in terms of how clinicians can support their patients through this process and those things that they're feeling. Is there anything else you think is important as a clinical takeaway from this study? Do you
really get to know your patients and have conversations with them. It's absolutely fine to spend a whole half an hour with your patient just talking with them. So we should be able to use our coaching skills rather than just therapeutic conversations, have coaching conversations. And it might be that at some stage they might reach a stage as well, post-rehab, or at some stage where they have to make a decision whether they're really going to go back to that sport or not, or what the options are. So that is a really important consideration take home from our study. Not for all, again, just want to emphasize that, but as a clinician, you will have to identify what is relevant to the patient. So using coaching skills to find out what is important to them and what they would be willing to change, particularly if the fear of re-injury is high, or the anxiety or kinesiophobia, whatever you want to call it for now. So get to know your patient and really listen to them. Perhaps we need, I wonder whether we need to tell them ahead of time that it's possible that they'll go through dark moments as part of the rehab, but come and talk to us. Then obviously as physios, we would have to screen whether they need referral onwards, or whether this is within our scope to support them, get them over the hurdle. And support them making their own decisions. So it's not only the physicality, it's also the emotional. And from the ACL studies, I remember there was one person who said, well, when I start feeling more anxious, that's when I know that I have to start again to strengthen my thigh. So that person was using physical rehab to address his emotional or psychological impairment. Of loss of confidence. So, and that's how we as physios, we are good at the physical aspect of the rehabilitation. That is part of the person-centered care. But perhaps there are some patients where we also have to delve into conversations with them to find out how they really are, what is important to them, and if they can't get back to rugby, what options would they be willing to think about?
I think something, since I've been working with you on this project, I sort of, with a shoulder instability patient, I also ask routinely, how is this affecting you? You know, just as a broad starter for how are you affected by this? Are you doing okay there? And also it seems very reassuring for them to know that they are not the only ones who feel like that. You know, because like you say, it's very isolating.
Yes.
But when I tell people that it's really common, they're quite relieved
Yes.
to know that
Yes.
they're not, because they're in their own journey with that, aren't
Exactly.
they?
Yeah.
So learning that, yeah.
Yeah. Just one more point. Some patients also picked up or highlighted their problems with sleeping.
Yeah.
Again, with ACL injuries, they're normally at risk when they are doing loaded movements, like when they're out of the house or on the sports field. People with shoulder dislocation can dislocate the shoulder in their sleep, or
Yeah.
just by pulling up a duvet at night. So there's never a time where they're not at risk. And
Yeah.
adds towards sleep. It's not only about sleep systems, not only about pain, not being able to lie on it. It's also about the worry of perhaps dislocating it while they sleep.
Yeah, and the lack of
So that is
trust.
something to explore with them.
Yes, okay, to keep an eye on then.
Yeah.
So more sort of routinely, I should also be asking people how they're sleeping and if they feel safe maybe, or yeah. Hey Gisela, I keep learning so much about this that has just been fascinating for me.
Well, we're learning from our patients and we're learning from our participants. And that is what I love about qualitative research.
Yeah, it's a really powerful piece of work. So thanks for all your energy in this space. It's been really great. Is there anything else you wanted to say to conclude our podcast? Anything else you wanted to share with people?
I want to say, in the long term, I am mainly in an academic field now, but I'm working with you, Margie. I'm working with a clinician, a specialist clinician. And the more we've got those collaborations, and including patients, orthopedic surgeons, the multidisciplinary and the stakeholders, we really need to grow those collaborations, and we are. And just want to emphasize that everybody has a role to play in improving the outcomes of these and also other injuries. Yeah.
And so for clinicians to reach out to their local academics, with the ideas, because they're the people on the ground, aren't they?
Yes, absolutely.
And to really grow those connections so that we can better help these people and better understand what's really going on.
Yeah, so absolutely.
Yeah,
thank you very much for having me, Margie.
Thanks. Thank you. Every time I talk to you, I learn something different. So it's been fabulous. Thank you.
Both ways. Okay.
Thanks for joining us for today's podcast. I hope you've really enjoyed this content. You found some clinically useful tidbits, and some of the content has been thought-provoking. If you have other ideas for content for these podcasts, then please reach out to me on social media via Facebook, Instagram, LinkedIn, or Twitter. I'm happy to get your feedback about the content, and if we can improve that in any way, or talk to researchers or clinicians who you would like, then I'm happy to do so. Don't forget, you can follow me on my social media for some more up-to-date content. You can also access me for patient-specific help. If you'd like to do that, then I also offer that service via Telehealth Worldwide. If you're looking for a shoulder brace, you can check that out via our shoulder braces on flawlessmotion.com. And if you wanted an online shoulder course, then I have a range of shoulder courses, through from an introductory shoulder course through to return to sport and a shoulder instability course. The instability course was designed to accompany the clinical concepts paper that we published in the Journal of Athletic Training. You can access these courses on margieolds.com or flawlessmotion.com. That's flawlessmotion.com. And every course comes with a complimentary question and answer session, so we can drill into your understanding of the key concepts of the course. You can also join our Facebook group, Glenohumeral Gurus, and follow along for the conversations and discussions on this page. And otherwise, I look forward to you joining us for the next podcast. Thanks for your time. Until then, stay well, take care.